All right, should be pulling up. So just really here, this is going to be, there are going to be little pieces of this that may not be directly relevant, but I think it might be important for everyone to know kind of what's happening around the state. As we know, there aren't enough mental health providers in Montana or probably in general, but and the first line of defense or offense when it comes to psychiatric illness are primary care clinics. And again, knowing that anybody involved in corrections is probably in the same situation. Well, not probably. We know we're in the same situation. But I'm going to tell you a little bit about what's happening in primary care. So as you guys all may have heard of the term integrated behavioral health. Integrated behavioral health is sort of the umbrella term for when you're trying to provide behavioral health services through a primary care clinic. And not every primary care clinic is equally prepared to handle behavioral health issues. So there's the most robust evidence-based model for doing this is called collaborative care model, and that was developed at University of Washington. There have been about 80 randomized controlled trials to demonstrate that this is much better than practice or treatment as usual. And so it's actually got to the point where there are actually new billing codes for this model in particular that were just rolled out in January. So you're going to be seeing a lot more of this in Montana, across the country in general, but in Montana especially. So just a quick introduction. What are the principles of collaborative care? And these are sort of the key elements that in order to have collaborative care, which again is the specific model of integrated behavioral health that has been shown to be most robust. If you can just read closely what I have here. I'm kidding. I'll read it for you. I'll just mention the five main principles here. One is it's patient-centered team care, right? So patient-centered is critical, right? So any treatment plans are developed in conjunction with the patient, and was the patient really as a critical member of the team, obviously. Next is population-based care. And population-based care, I think, is really important because one of the key elements is actually a patient registry, right? So imagine, right? I think we all had hopes that electronic health records would allow us to do something like have a registry where you could look at a dashboard of your patient population and be able to sort by low, medium, and high risk. When's the last time they were seen? Do they have any history of suicide attempts? And be able to organize your patients by risk. But clearly, our electronic health records don't do that. But there are some patient registries that are being made available and that we're going to try to be using to be able to start doing this with patient populations. So that's what population-based care is. Next is measurement-based treatment to target. Again, one of the things we don't do really all that great in mental health is really stick to kind of robust outcome measures and track them. So collaborative care does a really nice job of, especially when it comes to anxiety and depressive disorders, using some very clear-cut scales and measures. So for depression, it's PHQ-9 depression scale, and for anxiety, it's the GAD-7. Next is evidence-based care, right? That's something we're all trying to do here through Project ECHO, working together to make sure that we're all adhering to best practices and the evidence. And in primary care, when you talk about integrated behavioral health, the different modalities that collaborative care tries to push out to primary care clinics is problem-solving therapy, behavioral activation, and CBT, or cognitive behavioral therapy. And certainly, I think one of the ones that's not mentioned here, but I think is central to primary care, is motivational interviewing. In the same way as it is for folks with addiction, behavior change around health behaviors is critical, obviously. And then finally, it's accountable care, where over time, we think the healthcare system is going to be moving towards really value-based care. In other words, you get paid for what you provide, for the quality of care you're delivering, not just for volume. Right, we're still a long ways. Excuse me, we're a long ways away from that. But that's the hope with something like collaborative care. There's accountability that the quality of care that's being provided can be measured by patient outcomes. All right, has nothing to do with anxiety disorders, but that was my intro. Just a big picture, kind of what's happening in terms of integrated behavioral health and collaborative care and primary care. This is kind of the book that was created. Really. It's a nice book. It's written by the creators of collaborative care and really goes through a lot of these principles, and it goes through actually by disease state, by anxiety disorders, mood disorders, psychotic disorders, and says, okay, how could primary care practice address some of these issues? Okay, here's my presentation. All right, so no disclosures. So introduction to anxiety disorders, right? So anxiety disorders are more common than mood disorders. So 29% lifetime prevalence for anxiety disorders versus 21% for mood disorders. And remembering that mood disorders include unipolar depression and bipolar depression. And then, of course, all the other unspecified stuff. But in general, depressive disorders and bipolar disorders. And as we know, anxiety disorders, like all psychiatric disorders that are diagnosable, have impaired general health and psychosocial functioning. So anxiety disorders are a very real risk factor for suicide attempts, and they also lead to somatic symptoms or are associated with somatic symptoms. So again, assessment of anxiety disorders, right? Really taking a look at what's the chief complaint, what are the associated somatic and psychological symptoms, what is the functional impairment, and what are the safety concerns. So what I'm going to do is go through the different categories of anxiety disorders, and just kind of, again, this is, as you know, this is an overview for really what's a 20-25-minute presentation, but I'm going to go over kind of big picture key points around each one of the anxiety disorders. So you have generalized anxiety disorder, and sort of the psychological sort of pearls here. You're looking for excessive worry or fears, hard to control worry, irritability, poor concentration, and attention. And just, again, highlighting that poor concentration and attention can be associated with any psychiatric disorder. So, right, so when there's problems with attention and concentration, it doesn't automatically mean ADHD, right? Just knowing that that's a piece of most psychiatric disorders, right? Somebody who's severely depressed, not going to pay attention to a lecture. Somebody who has psychotic disorder, going to have struggle paying attention to a lecture, right? So again, poor concentration and attention is something that's seen across all disorders. Next, somatic problems. So muscle tension, feeling keyed up or on edge, fatigue, and sleep problems. Again, sleep problems also associated with most psychiatric problems. Next, panic disorder. On the psychological part or psychiatric part, fear of going crazy, fear of losing control, sense of impending doom or death. And the somatic symptoms, chest pain, palpitations, shortness of breath, trembling or shaking, sweating, nausea, abdominal pain, diarrhea, and dizziness. Social anxiety disorder or social phobia. Psychological symptoms include excessive fears of scrutiny, embarrassment, and humiliation in social or performance situations. Anticipatory anxiety. In terms of somatic symptoms, they include blushing, sweating, trembling, and palpitations. Wow, those somatic symptoms actually also sound like the ones you get when you're in love, I guess. So, next. Post-traumatic stress disorder, PTSD. Psychological symptoms, feeling keyed up or on edge, hypervigilance, exaggerated startle response, nightmares, flashbacks, irritability, anger, poor concentration, emotional numbing, avoidance, detachment, and estrangement. And somatic symptoms include problems with sleep and night sweats, right? And keep in mind, for many years, PTSD or trauma-related disorders were under anxiety disorders, and now there's sort of a separate section in DSM-5. But again, a lot of this feeling of hypervigilance and being keyed up, you know, there's still a lot of overlap with anxiety disorders. But for now, we'll kind of mention those as well. And also the fact that trauma is everywhere. So I think it's important to keep this in mind and always have this in the back of our mind. Next, obsessive compulsive disorder. So psychological symptoms include persistent and intrusive thoughts, ideas, and images. For example, the fear of contamination, the need for ordering things, and repetitive intentional behaviors. In terms of somatic symptoms, they include physical signs and compulsive behaviors. And for example, you see skin chapping, bald spots, or scabs from picking, right? The skin chapping from excessive washing of hands. So again, you'll see those physical signs that are manifested by the behaviors that are being displayed in OCD. So like any, right, this is also a nice reminder about any diagnosis in the DSM is you want to rule out organic causes or medical problems or substance-related problems, right? So before you go right to a psychiatric diagnosis, the question is there a medical problem associated with this patient that might be causing some symptoms, or is there a substance use problem that might be causing these symptoms? So in terms of cardiovascular problems, you have potentially angina, arrhythmias, congestive heart failure, hypotension, or myocardial infarction. In terms of GI or gastrointestinal symptoms, you could have gastroesophageal reflux disease or GERD, irritable bowel syndrome, malignancy, cancer, hematological problems, anemia, endocrine problems, you could have hyperaldosteronism and hypo or hyperthyroidism. And finally, in terms of immune problems, you can have anaphylaxis, lupus, or multiple sclerosis. More along the line of ruling out organic causes, you have metabolic problems like hyponatremia, so low sodium, hypocalcemia, low calcium, hypoglycemia, low sugar. In terms of neurological, you have encephalopathy, temporal lobe epilepsy, CNS tumors, TBI or vertigo. In terms of respiratory problems, you have asthma, COPD, pneumonia, and pulmonary embolism. And so now, sticking with the biological causes, now you're looking at substances. So you could have withdrawal symptoms from alcohol, opiates, sedatives, or hypnotics. And hypnotics, talking about like benzodiazepines. Intoxication, so intoxication with some medications or drugs, digitalis, anticholinergics, caffeine, hallucinogens, cannabis, and stimulants. And prescription medications here, SSRIs and antipsychotics, which can lead to akathisia. Again, Abilify tends to be one that causes this pretty often, where somebody comes in and has been newly started on an antipsychotic, might start to feel sort of some sense of restlessness, agitation, almost anxiety. But really it's like this internal restlessness that when you're trying to tease apart, is this anxiety or akathisia? And adding propranolol is often a very quick fix for this sort of symptom. Propranolol is simply a beta blocker, anti-hypertension medication. Next, bronchodilators like theophylline and sympathomimetics. And then you get oral or inhaled steroids. And again, steroid medications are responsible for all sorts of presentations that look like psychiatric problems. So what are functional impairments associated with anxiety disorders? Well, at education, in the school setting and at work, you have early difficulty in school, separation anxiety, missed work due to fear and avoidance. Whether it impacts relationships, especially whether there's a history of trauma, risk for domestic violence, and conflict due to irritability. And the ADLs, activities of daily living, inability to leave home. Feel free to read along. I'm kidding. Sorry about the small print. In terms of this is a good slide. Take a look at this when you get the PowerPoint. But essentially, what this goes through, it's nice. It goes through each one of the diagnoses, each one of the diagnoses that is actually an anxiety disorder or can masquerade as an anxiety disorder, or give you questions to differentiate between an anxiety disorder and another disorder. So the first column is what's the diagnosis. The second column are what are key questions to help you identify what we're dealing with. The next column is what's the differentiating symptom. And then finally, what's the behavioral health measure that you can use? So for the first, I'll read the first couple just so you know what I'm talking about, right? So for the first one, the diagnosis is GAD, generalized anxiety disorder. The key question is, have you been worrying excessively for greater than 6 months? Are you a worrier? The differentiating symptom is worry. And then the measure that you use is the GAD-7. The second one, panic disorder. Key question is, do you experience sudden attacks of anxiety or unexplained physical symptoms? The differentiating symptom is sudden, unexpected anxiety or physical symptoms. And then the behavioral health measure is the GAD-7. And again, this little guide will go through and help you with a bunch of other ones. So it has social anxiety disorder, PTSD, OCD, major depressive disorder, bipolar disorder, substance use disorders, and ADHD. This is the GAD-7. So the GAD-7 asks, over the last 2 weeks, how often have you been bothered by the following problems? And so the 7 questions that are asked are feeling nervous, anxious, or on edge. Number 2, not being able to stop or control worrying. Number 3, worrying too much about different things. Number 4, trouble relaxing. Number 5, being so restless that it's hard to sit still. Number 6, becoming easily annoyed or irritable. And number 7, feeling afraid as if something awful might happen. And then it's a very simple way to score. Yeah, the columns gives you a total score. You ask about what sort of impairment it might cause, and then you can interpret the score at the bottom, ranging from mild anxiety, moderate, severe anxiety, and possible diagnosis of generalized anxiety disorder. Either way, you can consider this a screener. It's not automatically, right? It just gives you that a likely diagnosis is mild, moderate, severe anxiety, but then going through the diagnostic criteria will help you nail down the diagnosis. This is the SCARED scale for children. So very fancy acronym here, Screen for Child Anxiety-Related Disorders, also known as SCARED. They have a child version and a parent version. So the child version can be filled out for anyone age 11 to 18 or 17. And then the parents one, parent ones could be filled out by anyone of any age for the child. But again, these are focused on kids. They have about 41 questions. I won't go through each one of these, but it allows you actually to differentiate between panic disorders, school avoidance, social phobia, generalized anxiety disorder, and it's pretty nice. It only takes, even though there are 41 questions to be kind of checked off, it takes about 3 or 4 minutes to be filled out, and then takes about another 3-4 minutes to score. It's pretty nice. The other thing to really point out too is that, keep in mind, anxiety disorders, in addition to being, more prevalent than mood disorders in adults, in kids it's the same thing. If you look at a population of children, the most common diagnosis is anxiety disorders. After that, after anxiety disorders, they call them behavioral disorders, but it's really ADHD and opposition defiant disorder. After that is when you're looking at mood disorders, which include depression and bipolar disorder, and again, bipolar disorder is exceedingly rare in kids. So treatment, I know I'm bumping up against 25 minutes here, so I'll try to make it quick. Treatment, right, so looking at those including psychoeducation, safety plan or a plan, psychotherapy, and pharmacotherapy. So psychoeducation, one of the tools I like to use is this bell curve, where if you look at the left or the y-axis here, the up-down axis, it's a measure of functioning, 0 to 10. 0 is terrible functioning, not functioning at all, and 10 is perfect functioning or optimal functioning. And then on the x-axis, or the horizontal line, is the level of anxiety, 0 to 10. 0 is no anxiety at all, and 10 is maximal anxiety to the point of freezing, right? So every single person, I think, has their own bell curve where there's at some point there's optimal functioning, and it's unlikely to be at 0 anxiety, because if there's 0 anxiety, you'll cross the street not worrying about anything, and that leads to problems. And then if you have maximal anxiety or a 10 out of 10 anxiety, you're not going to cross the street at all because you're too scared to get hit. So at some point, there's an optimal level of functioning that's a mix of a certain level of anxiety, which then allows you to function in a way that, well, you can cross the street when it's safe, for example. Risk assessment, one of the things that's important to keep in mind, there's a study, and again, we continue to study suicide risk, but there was a study in the early 90s that was one of the few, or the first prospective studies of suicide and suicide risk. And they found that anxiety disorders, so overall, anxiety disorders more than double the risk for suicide compared to folks with no anxiety disorder. So odds ratio of 2.2. In other words, the odds are over 2 times higher for suicide attempts in somebody with anxiety versus not. And this is a little a silly mnemonic I created when I first came across this study, because it really identified what are risk factors for suicide attempts between now and 6 months out. And they include these things: psychic anxiety, basically just means anxiety, right? Almost like generalized anxiety. Panic attacks, concentration is decreased, alcohol, sleep is impossible, and anhedonia, or lack of interest in doing things. So these were the 6 factors that were significant risk factors for suicide in the upcoming 6 months. So again, more predictive. one of the things they actually measured was suicidal ideation, and they found that suicidal ideation was not predictive. In other words, panic attacks are a much better measure of suicide risk than somebody saying, yeah, I'm suicidal. This is a safety plan. I think we've talked about safety plans in the past, but you just go to suicidesafetyplan.com. This is a research-based intervention that allows you, especially we use this for everyone that comes to the emergency room and if they get discharged, and also for everyone that gets discharged from our inpatient units, we do a safety plan on everyone. So basically it's a CBT-based tool that starts at the very top with what are warning signs or what are your triggers for anxiety, for suicidal thinking or severe distress. Number 2, what are your internal coping strategies, things you can do on your own to take your mind off your problems or stressors? Number 3, name 2 people, 2 places that are good distractors for you to help you take your mind off suicidal thinking. Number 4, who are 3 people you can ask for help? Number 5, names of professionals or agencies you can contact during a crisis. And then finally, what are 2 things you can do to make your environment more safe, right? So if you have a loaded gun under your pillow, get rid of it. Things or razors under your bed, get rid of them. So anything to make the environment more safe. The other thing that's actually not here on this one, I don't know why, is one I like very much, is at the very bottom, at least in the ones that we're using, we ask, give me a reason for staying alive. In other words, and then this goes also to a question I ask everyone who when I'm doing suicide risk assessment, I ask, why haven't you killed yourself yet? Why are you still alive? And that sort of pushes the patients to think about what stopped them so far. So every single person I've done an assessment on is ambivalent. There's part of them that wants to be dead and part of them wants to be alive. And I'm trying to understand what part of them wants to be alive and how convincing they are. There's psychotherapy for anxiety disorders. There's CBT, right? The connection between thoughts, feelings, and actions. I think many of us here on this call are familiar with this. Also mindfulness, mindfulness interventions, pharmacotherapy. Consider pharmacotherapy or medications in moderate to severe anxiety disorders. And these 2 SSRIs are the ones with fewest drug-drug interactions. One is Lexapro or escitalopram. The other one is sertraline or Zoloft. And there are lots more, but again, I'm just kind of focusing on 2 for here. FDA-approved anxiety medications. You can go through. You can go through all of these at your leisure in the presentation. And one of the things is this is sort of eating crow on buspirone as I was looking more closely at the research and the literature. I think you've heard me say, I'll leave everybody else to their opinion, but I know I've said over and over again, buspirone, that stinks, doesn't work, doesn't stink. Well, it turns out it doesn't work at doses maybe people are used to seeing. And so looking at the research, when they compared diazepam or Valium to buspirone, they showed that actually buspirone is as effective as Valium and superior to placebo. And diazepam or Valium was actually not faster acting. So there are lots of myths around buspirone that I got sucked into. I got sucked into several of those, that it's, it doesn't really work. But it takes 2 to 4 weeks to cause full anti-anxiety effect. And in terms of if the dosing is right, it can be very effective. Now, I think we've all seen when buspirone is being used in patients, especially in these presentations here and in this echo and others, they're often like 5 to 10 milligrams or maybe 20 milligrams a day. Well, it turns out you need to be pushing 30 to 60 milligrams a day. And these tend to be pretty helpful in patients who are struggling with depression, social phobia, and have a combination of anxiety and alcohol problems. Because again, you're not giving them a benzodiazepine that's potentially addictive and also acts on the same part of the brain as alcohol. Can be safe for medically ill or elderly patients. It doesn't depress respiration. It doesn't impact coordination or cognition. And it doesn't have, and these are the side effects that you can see: headaches, nausea, dizziness, and tension. Off-label medications. Lyrica is a good one. There's gabapentin and there's pregabalin. Pregabalin is much more expensive, but at least some of the research that's been done shows that pregabalin or Lyrica can be better for anxiety than gabapentin. It's actually approved for generalized anxiety disorder in Europe. We haven't approved it here in the United States. And studies show that pregabalin or Lyrica is as effective as Xanax and venlafaxine in generalized anxiety disorder. And these are a few other things I won't get into. This is actually a nice book. I may have shown this to you guys before. This is a kind of a little like almost like a little cheat sheet kind of book for DSM-5. And instead of giving, looking at the whole big DSM-5 and saying, wow, this is too big, forget it. This is smaller, gives you actually some questions to ask for differential diagnosis, being able to understand what to look for in each one of these presentations and help you diagnose. So that's what I got. Sorry it was longer than it should have been, but there you go.